Anyone coaching older adult, just make sure you're checking their fracture history, if they do have any of those fragility fractures or things that could indicate that they have low bone density. Maybe you can even ask them if they have their bone density report, and you can make sure that you have all the information and you know exactly what their baseline bone health status is like.
Hi, Emmy. It's my pleasure to have you on Evidence Strong Show. If you could briefly introduce yourself.
Hi, thanks for having me, Alex. Great to talk about another, research study and exercise with someone who's pro exercise. So, my name's Amy Harding. I'm a research fellow from Griffith University. I'm in the School of Allied Health, Sport and Social Work. So, I've been researching musculoskeletal conditions for about 10 years now. I'm currently working on an MRFF funded project. So, that's like an Australian government funded study, the Stop Fracture study, and we're implementing a referral pathway to exercise and trying to embed that into the osteoporosis model of care. So, from a little bit of a different background than maybe some of your people that follow you and watch you.
No, the background is very relevant because today we're talking strength training and aging. So let's try to build some kind of background. What would you have to say about aging?
Well, it's a privilege, obviously, to become older, but we know from all of the demographic data that's coming out about the population in Australia and in a lot of countries that the percentage of the population that are older is increasing. And we've also got life expectancy that's increasing. So we know that people are living for longer and we want to try and keep them healthier for longer as well. So I guess in Australia, the Australian Institute for Health and Welfare did a report a couple of years ago, and they said that 1 in 6 Australians was over 65, which is 16% of the population. That might not seem like much in relative terms, but when we talk about absolute terms, that's 4.2 million older people. So that's a big chunk of the population. So aging itself, back to your question, what happens when we get older? Well, specifically with musculoskeletal conditions, we're thinking about things like sarcopenia. So that's like loss of muscle mass and muscle strength and function. Osteoporosis, which is my area of interest, that's reduced bone density and an increased propensity to fracture. And then we've got other things like osteoarthritis. So we see our joints, our cartilage starts to get a little bit, worse for wear as well. Also, apart from musculoskeletal conditions with aging, we've got metabolic, neurological, cardiovascular conditions. So there's lots of things that can deteriorate as we get older. But the great thing is exercise can ameliorate all of those conditions. So keeping active is really important. Probably the other thing to remember is that 1 in 4 older adults have a fall every year. So falling is also a really big risk of injury for this group. So that's something else that can also be improved with exercise. So that's your balance.
Okay, with falling, let's just add a little bit of relevance. So the fall is a problem already because it's a risky event, but then what happens after the fall is risky too. Could we speak a little bit about that?
Yeah, so when we're thinking about older adult that fall, a lot of them will have low bone density. So they might have osteopenia or osteoporosis. So the fall itself might not be that bad. It might be something like a trip or a slip. So from standing height hitting the ground. So not particularly, a big change in height of the fall, but they can have things like fractures, fracturing their wrist, bones in their hand, their shoulder. But the big one is really fracturing a hip. So when some people, older people fall, they might fracture their hip. They have some really bad health outcomes after that. So a lot of them will lose their independence. So they need to go and live in aged care, or even worse, they just remain in hospital. Their health deteriorates. Their morbidity and mortality is huge with hip fracture. So when we're thinking about falling, the kind of big one we want to avoid is the hip fracture.
So let's talk a little bit about your PhD and 2 other studies associated with it. The goal is simple, get people better, but specifically what you are aiming for.
Yeah, so I guess our research group has always been interested in musculoskeletal conditions. My supervisor for my PhD, who's now my boss in my research role, she had done a study called the LIFTMOR study with one of the other PhDs in our research group. So the LIFTMOR study was looking at a particular kind of exercise program. So that was a high intensity resistance and high impact training program. So we call that HIRIT, just for the acronym. So that training program was in postmenopausal women with low bone density. So they had an osteopenia or osteoporosis. So that original study, the LIFTMOR study, was done by Dr. Steve Watson, and they found some really fantastic results. results in that study. So they had really excellent increases in bone density at the spine, some changes in the hip, and some geometric changes as well. So sometimes we can have changes in the geometry of the proximal femur or the femoral neck that will make it more resistant to fracture. So you're making the bone stronger because it's changing its geometry, but it may not necessarily be changing the actual density. So there's some other kind of factors that come into play there. So the LIFTMOR study basically found that it was effective at reducing their risk of falls and reducing their risk of fracture. So they had better balance, they had better muscle strength, better mobility. Therefore, if you're less likely to fall, you're less likely to fracture. And the bone density was also increased. So their bones were stronger and they were less likely to fall. So overall, that's a fantastic result.
Awesome. And then you decided to do your study. So what your study was about?
Yeah, so then we decided, well, we know this exercise program is effective in women. Now we need to know if it's equally as effective in men. So we just replicated the same exercise protocol in older men. So that was 45 and older, and they had low bone density as well. So we use a particular kind of machine called a DEXA scanner or a bone density scanner. So we should be able to quantify what their bone density is like when they join the study. So every participant in our study, the LIFTMOR for Men study, had osteopenia and osteoporosis. So that's just low bone density or low bone mass. So then we did the same protocol with the high rate exercise program, and we did that for 8 months. And we basically did a whole lot of measures before and after the 8 months. So we could look at the fall and fracture risk, the same as what we did in the LIFTMOR study.
All right. So I think it's a good time because coaches will be super interested to hear about what the exercise program consisted of.
Yeah, sure. So the program, the high rep program, was high intensity resistance and high impact. So the high intensity resistance component was some compound movement exercises using barbells, and we aimed for 80 to 85% of one repetition maximum or 1 RM. So that was different exercises that are targeting specific muscles around the bones that we want to try and increase the density of. So that's the spine and the top of the femur, the top of the thigh bone. So we did a deadlift and squat and then an overhead press to get some axial load as well. So they were the 3 resistance training exercises. The impact exercise was kind of like doing a chin up on a chin up bar and then dropping to have a little bit of a heavy impact on the ground. So that was, we call it like a drop chin. So some people might be familiar with like drop jumps and things like that. So that's where we're working on getting impact through the bones.
That's awesome. And how was it, twice a week, 3 times? How often the participants were?
Yeah, so they did twice weekly exercise. So we think that's a good achievable amount for people. Also, a lot of the recommendations for resistance training and older adults out there really say twice weekly strengthening. So we thought that was something good that people could fit into their calendar. So something achievable twice weekly.
All right. And you ran the study for 8 months.
Yeah, we did 8 months. Generally, when we're talking about being able to detect changes in bone density, you need at least a minimum of 6 months. 6 to 12 months is kind of the range that most researchers will work on. Anything less than 6 months, it's a little bit unlikely that you'll be able to detect change using the kind of device that we scan the bones on. So that's the bone density or the DEXA scanner. So we've just added a little bit more for the 8 months just to make sure we were catching everything.
So the changes in the muscle will be visible, even to the naked eye, will be visible faster probably. But bone requires repetitive loading for a longer period of time. Why do you think it is?
So bone density, it's just the way that all the little cells work in the bone kind of microenvironment where they actually need a full kind of remodeling cycle. So they lay down, little bones kind of little cells chew away at the bone, and then some other cells move in and lay down new bone density. So that's quite a kind of long process in comparison to when we're looking at muscle changes like hypertrophy or hyperplasia. They happen a lot faster. So that's why some of the studies look at bone density take a little bit longer.
How did you structure the progression?
Yeah, so the intensity we were aiming for was 80 to 85% of 1 RM. So we did some 1 RM testing at a couple of time points in the study as well, just to ensure we were at the right intensity. We also used a Borg scale. So some coaches might be familiar with that. That's a scale where you can kind of, I guess, a participant or a client can stand there and kind of rate how hard the exercise is based on a scale. So we used a 6 to 20 Borg Borg scale, and they were aiming for 16 and higher. So that was kind of another way of being able to ensure we were in the right intensity. I did all of the coaching of the classes myself, and I find people are really responsive, even individuals that have never really been in a gym before, to being able to quantify their intensity by using repetitions in reserve. So that's where you're able to kind of train them and teach them that how many reps did you feel like you could do after you'd finished your set. If you felt like you had 2 or 3 more in the tank, we can add a little bit more load to the barbell. So that's a really easy way of the client also, or the participant, being able to control what their intensity is like as well.
Okay, in terms of testing, so 1 repetition maximum with older adults, some people may be a little bit reserved. What would you say to that?
Well, we did it in our study at 12 and 24 weeks. So they'd had a little bit of time, they'd developed their technique, they were familiar with the exercises, their tissues, and that it had time to adjust to that kind of activity, particularly for people where they're not familiar with doing the gym and they might be a novice, so to speak. I found that was quite easy to do. If you've developed a good technique with people and they understand why they're doing what they're doing, 1RM testing is completely fine for me. I understand reservations some coaches might have. So you can really easily do like a 3RM or a 5RM, or even just an AMRAP as well, is a really great way of checking intensity. So you can use some online calculators to, work out what kind of load they need to be at to get a certain intensity. In respect to your question, myself, I had no issues with the 1RM testing. It was fine.
Okay, in terms of participants, how did they perceive the program?
I guess we started with a familiarization period where they developed a really good foundation. So they had really good movement patterns. And then we just gradually, increased the load over time. They felt really comfortable. They knew that I knew what I was doing, and they understood what the exercises were targeting and why we were doing that kind of program, so they could improve their bone health and, reduce their risk of fall and fracture. Generally, older people might be a little bit turned off by the gym. It's not an environment that they like. But I think when people know that ultimately they're going to be healthier, they're going to be happier, they're going to have a longer life, they're going to reduce their risk of lots of conditions. They might not particularly like the exercise, but they know that they need to do it. And gradually, once you get past that kind of 3-month mark, you see people really going, oh, you know what? I actually really like this. This is great. Like, I feel like I'm coming in, I'm doing something that people don't expect me to be able to do. I feel really empowered. So I don't know, I think people get a switch once they get past that 6-month mark or that 3-month mark, where they're like, oh wow, this is actually great. So we actually did some interviews after the completion of the study with all the participants, and a lot of them had continued to do resistance training, either set up a little gym at home or even gone and engaged an exercise physiologist, or like you, a physio, who was continuing to do some exercise programming for them. So they'd, completely fallen in love with exercise and resistance training. So yeah, I think if people know that it is good for them, it will drive them to do it a little bit.
I even see that the work you guys doing the clinic could have some collaboration with weightlifting gyms or powerlifting gyms in the area, and just send these people to the coaches there, and where they can keep the group environment, the encouragement, and the progression, so they actually get stronger and have opportunity to be involved in competing, or just supporting other people who do the same. I think that could be a really good collaboration.
Our research group, we were really lucky in that we have a great head of our research group, Professor Belinda Beck, who's been my mentor for 10 years now. So we found all of these great results from our studies, like the one that I did for my PhD, the LIFTMOR for men and the LIFTMOR for women before that. So then we did another study with another PhD after mine called the MEDEX OP study. So they replicated the same exercise program again. And we found all of these results, and Professor Belinda Beck was like, this is too good not to be able to have people out there accessing. This is so good for health and, reducing fracture, reducing falls. We've got to roll it out in the public. So she actually started the Bone Clinic in Brisbane. So that's a translational research facility that she runs. So people can go there and do the exercise program, which is called the ONERO exercise program. So that's exactly based on what we did in all of our studies. So they can go to the clinic in a real world scenario and do the exercise program with an exercise physiologist cardiologist, and they're having some fantastic results over a number of years now, more than 6 years in the clinic, at the bone clinic. And that exercise program, ONERO, is also at allied health clinics all around the world and around Australia. So we found this, fantastic program, and now people can go and do the evidence-based program, exercise professionals. So that's really fantastic.
That's amazing. You used something called biodensity. So could we talk a little bit about that?
So this is a kind of machine that was, I guess, a little bit more popular in North America than it was here. So we had this biodensity machine, and there wasn't too much research about the effectiveness and the safety of it. So that biodensity machine is essentially kind of a multi-station machine where you're doing a near maximal isometric contraction. So it was kind of like a chest press, a leg press, a stimulated kind of deadlift, and almost like an underhand chin up. So them kind of similar movements to what we had in the high root protocol. So that biodensity machine, we then thought, well, we can also look at that in our study, LIFTMOR for Men. So they were the two groups. One group did the high rate program, one group did the biodensity machine. We matched the frequency for the two groups as well. That biodensity machine now is the OsteoStrong, so that people might be familiar with that name. There's a few centers popping up around Australia now. Generally, they only recommend, or the manufacturers recommend, once weekly. So we just did the twice weekly just so it was matching the frequency for the two groups in the study. We were looking at about 35 in each group. So they had really good compliance. Almost 78% completed the whole 8 months, which is generally quite good in a research study kind of setting. So yeah, then we did the same measures pre and post, and we compared all of the results between the two groups. We did a really quite a big suite of measures. I guess kind of the key ones were related to bone density. So that was using the DEXA. So we looked at lumbar, spine, femoral neck, and total hip bone mineral density. So that's just like the massive bone at particular parts of your skeleton. We also looked at scanning parts of the forearm and the leg. It's something called a PQCT, or a peripheral quantitative computed tomographer. That's basically a 3D scan. So the bone density scanner is only two-dimensional. This PQCT scan is 3D, so we can look at the volume and the area of the bone and the muscle as well. And then we also did a lot of other measures that coaches might be familiar with, like things about balance and mobility. So tandem walk, climbed up and go, 5 times sit to stand, functional reach test. So some kind of battery of pretty commonly used tests in, I guess, exercise studies. So that would facilitate comparison with other studies as well. So yeah, a whole lot of measures that we looked at, all really indirectly related to fall and fracture risk.
Amazing. All right, are you ready for the results?
Okay, so I guess that the key things were with the results that the high rate group saw a 4.1% increase in lumbar spine bone mineral density, which is really fantastic because as we age, we tend to see a decline in bone density. So even maintaining or increasing bone density is something that is fantastic. So that was the kind of the main key result. They also increased their trochanteric bone mineral density. So that's a particular part of your femur where a lot of muscles attach. And that was 2.8% increase there. So some really good improvements in the bone density. That was also a little bit higher than what was observed in the biodensity group when we did the between group comparisons. So yeah, slightly better increases in bone density for the high rate group versus the biodensity group.
You mentioned that then the natural history is that people lose some bone density as we age. Well, how much of a loss it is?
That varies a little bit depending on what ethnicity and what kind of age bracket you're looking at, but generally it's about in the realm of 2.5% per year for men, slightly more for women. After menopause, with the withdrawal of estrogen, they get a little bit more of a rapid and more marked decline in bone density than men. So maintenance of bone mass is an excellent outcome, and then even improving it is even better. So we know from some of the research out there that, even a 1 to 2% increase in bone mineral density can translate to a 5 to 10% reduction in fracture risk.
Are there any tools to predict, or without sending participants or clients for DEXA scans, are there any way to assess bone health in older adults?
I guess when you're thinking about risk factors for fracture, you can really, ask some very easy questions to determine that, like a history of fragility fracture. So that means a fracture fracture from a trip or a slip or even something as simple as coughing or twisting. So if you have a fracture in the past, that automatically increases your risk of having subsequent fractures. So that's a really easy question to ask if you're a coach when you're doing your, pre-screening with someone. Have you had a fracture? What kind of scenario surrounded those fractures? And then you can work out if maybe it wasn't, a low trauma or a minimal trauma fracture. Age, obviously, the older we get, the kind of most likely the lower your bone density. So you can ask them, what their age might be. If they're drinking alcohol or smoking cigarettes, that's some other kind of key risk factors for fracture and poor bone health. So you can ask some of those questions independent of having the bone density scan. That's something really easy for coaches to do. But generally, I think most women over 50 probably most likely would have had a DEXA scan done or a bone density scan done. So there's heaps of great resources out there. Healthy Bones Australia, if any coach is interested in learning a bit more about bone health, pop Healthy Bones Australia into your search engine and they've got fact sheets on there. You can learn a lot more about osteopenia and osteoporosis. So I think that's a really good starting point. If you're a coach out there and you don't know too much about this world, start with that. That's a really good resource as well.
All right. So in terms of bone density, you found improvement. How the participants, how did they do in other measures?
Yeah, so they increased their muscle cross-sectional area in their forearm, which was great as well. And some of the geometry of the bone at the forearm and the leg improved for the high risk group. Not too many changes in those kinds of things for the biodensity group. So high risk was definitely superior with some of those geometric changes and the muscle cross-sectional area. Some of the other things that improved were the 5 times sit to stand and the timed up and go. So the high risk group saw some improvements in just their general mobility and physical function as well. Yeah, their 5 times sit to stand for the high risk group improved. We also did some handheld dynamometer. So that's like a little device you can measure muscle force with. They also improved their back muscle and leg muscle strength as well. So, as you would expect with any kind of compound movement, barbell by 80 to 85% of 1RM, we saw strength improvement. So that was great. And that was actually more in the high risk group than what we saw in the biodensity group, which I guess would somewhat be related to it being an, isometric or a near isometric contraction. They're not really going through a lot of, eccentric, concentric movements there.
Awesome. I have a question about biodensity. So you said that it was effective in improving bone density in the axial, so kind of, this direction. So the bones like spine and hip bones, thigh bones, these would be the ones that are influenced, not so effective in influencing the upper body bone density, would you say?
Yeah, it didn't have too much effect at the radius in the forearm when we did those PQCT scans or those 3D scans.
Why do you think it happened?
I think with the population that we're looking at, they were, relatively untrained, I guess you could say. Like not many of them had any background doing resistance training or any kind of strengthening exercise. They were generally doing a lot of just weight bearing, cardio based walking, stair climbing, little bit of jogging, cycling, so non-weight bearing activity. So really, I guess they did have enough stimulus to get a little tiny increase in bone density, but nothing too significant. Definitely the high risk group was superior with the bone density changes.
Okay, and the exercise also gave participants the increases in the functional tasks. So they can better movers and bigger muscles.
Yeah, all that good stuff that we love about resistance training.
It seems like not only the intervention was effective, but it was life-changing. So these people changed their lifestyle after having the support for 8 months. No doubt that was very smooth introduction to strength training, very structured, monitored, safe. And after that, they decided, this is good for me, I will continue.
Yeah, definitely. I think I'd really instilled in them how important it was for them to focus on their health. And if they wanted to age well well to continue to be active, try and reduce your time being sedentary. Make sure you're doing weight bearing exercise, like still do your walking, still do your cycling, your swimming, all the things you love, but make sure you keep doing your resistance training and your impact and those additional kind of balance exercises. So we don't want you to fall. We want you to stay upright. We want you to stay strong. So yeah, they've continued. I really instilled in them how important it was. I think I gave them a good kind of foundation, like I said earlier, to exercise and resistance training, and they've just continued on, which is really nice to see. Some of them had, aside from all the measures we took, they just reported how much better they felt, how much more energy they had, how much more their joints and their function were better. They had, their knees that would be like, oh, I've got a bit of a niggle in my knee. The knees felt better, their hips felt better, their back felt better. And I was like, yeah, this is what happens when you do resistance training and you're doing it properly and you're doing the right exercises and the right weight. So I think coaches out there, it's really important that they're there supervising, making sure people have the right technique, making sure they've got the right load progression. Yeah, all of that good stuff that exercise scientists, exercise physiologists and physios can do to help people keep living healthy, long lives and keep them out of hospital.
So let's bring it all together. What would be your advice for coaches who want or will work with older adults?
Yeah, so I think anyone coaching older adults, just make sure you're checking their fracture history, if they do have any of those fragility fractures or things that could indicate that they have low bone density. Maybe you can even ask them if they have their bone density report, and you can make sure that you have all the information and you know exactly what their baseline bone health status is like. There's also some other really good resources out there like Healthy Bones Australia, so you can make sure you increase your knowledge in that area. Also, the Exercise and Sports Science Australia position statement on exercise prescription for the prevention and management of osteoporosis. God, that's a mouthful. But that was a paper that was published back in 2017 in the Journal of Science and Medicine in Sport. It's a really excellent summary of osteoporosis and fracture risk. And then it goes through exercise kind of programming and prescription for these older adults that might have low bone mass. And you can kind of risk stratify them to determine what kinds of activities and what kind of repetition range, intensity range, and what kind of impact you can do, depending on some of those easy questions to ask, like fracture history and their bone density results. So yeah, if you're interested, make sure you check that one out. That could be a good place to start. Also, the ONERO program, that's the licensed program where you get a lot of additional training in the bone health area. So if coaches like exercise physiologists or physios were interested, you can also find out more about the ONERO exercise program. You can access that online. They've got the ONERO Academy website, so you can check that out online. I guess the important thing to remember is that when we're thinking about older adults, improving muscle strength, reducing their falls risk is key. We know that most fractures happen when people fall. So if you can prevent even the first fall, you can hopefully prevent, 90% or nearly all of their fractures. And make sure we keep the messaging positive as well about what you can do. Supervision, exercising with the coach watching you, making sure you've got the correct technique, correct load progression and intensity. That's really important as well. So yeah, I guess just keep doing what you're doing, coaches. Always try and keep learning more, particularly if it's an area that you might not know a lot about. And there's heaps of good resources out there as well.
Anything special coaches should be aware with postmenopausal women?
I guess also maybe check what other kind of medical conditions and medications they might be on, particularly if they are on any of the anti-osteoporosis medicines. That's probably something important to keep in mind, particularly if they decide to discontinue any of those, just to keep a check on everything and make sure, they don't have any change in their symptoms or any other pain or niggles that are kind of ongoing that might need some further investigation. But generally, I think everyone should be doing resistance training and strengthening their bones and muscles. People might not realize that exercise can improve your bone density. There's still a lot of people in the clinical space and a lot of patients that think that their bone density will never be improved with anything but medication. So it's important for coaches to know that exercise can improve your bone density, which is key.
Awesome. Thank you. 2 short questions to finish. The first one is, what is your favorite exercise?
Like specific exercise in the gym?
for you? What do you like?
Oh, I really like a deadlift. I really love anything row related. I used to love training back in the gym. So I love the bent over row that's just with a barbell. It feels so good. I haven't been in the gym as much lately, but I'm hoping I'll get back in there and I'll be deadlifting and rowing.
Awesome. Where people can find you online if they want to follow your work, ask a question, where should they go?
Yeah, so I'm on Twitter. I'm not particularly active, but if you shoot a question or you follow me there, so Amy_T_Harding. So I've got my photo there too, so you'll be able to see the bright red hair in the picture. It should be easy to find. Generally, if you wanted to find me, you can just search Griffith University, and if you pop my name in, it should take you. We have like a little kind of staff research page, and that should have my email address on there too. Yeah, so just feel free to reach out. That's pretty much it. Twitter and emails. That's where you'll find me.
Awesome. That's enough. Thank you so much, Amy. It was a pleasure.
Thanks, Alex. Great to have a chat. And everyone, keep exercising.
Yes.